Let's talk about rectal spacing for a moment. Another one of my interesting little side passions. So right now there are three products on the market. You've got SpaceOAR, you've got Barrigel, and you've got BioProtect, and they all create space. And if we're going to really kind of talk about the differences here, SpaceOAR, the first one that was on the market, is a polyethylene glycol, and it polymerizes when you inject it. Barrigel is a hyaluronic acid, and it's comes in a syringe. It doesn't polymerize. And the newest kid on the block is this BioProtect balloon, which is an actual physical device. It's made out of Vicryl. You fill it with salt water, and you could insert it in the space. And there are all some, sort of different pros and cons of these products. And if we talk about mean spacer volume, and these were taken right off of the pivotal trials that led to our approval by the FDA, you can see that both SpaceOAR and Barrigel are fairly similar at about 12.9 cc's, and the BioProtect balloon is actually a little bit more volumetric. Of course, you could put in as much or as little of the non-balloon constrained products as you want, but part of that has to do with how they are prepared in a kit. So what about other things? Let's talk about positional control. With the first product on the market, SpaceOAR, you basically inject this over 10 to 20 seconds, and you don't really have the ability to reposition it. You hope it goes where it goes, and skilled people who do this can get it good mostly every time, but you don't really have the ability to adjust it. Barrigel kind of addressed that issue because it's non-polymerizable by letting you sort of add some here, add some there, and so their sort of claim to fame is this sort of sculptability. But the balloon is also adjustable because it's this physical device, and before you inflate it or as you inflate or deflate it, you can sort of reposition it. So it can be repositioned before deployment. And then if you look at volume control, you can always add more SpaceOAR, you could always add more Barrigel. But another kind of interesting distinguishing feature of the newer product is you can sort of fill or remove as much fluid as you want before final deployment. And then if you look at innate stability, all of these are absorbable materials. SpaceOAR is about 5 to 6 months before it starts degrading, and there's no way to force degradation. So if it goes somewhere you don't want, you might have to involve a surgeon to remove it. Barrigel has another interesting property here, which is you could use hyaluronidase to melt it. So if you don't like where it went and you actually wanted to get rid of it, there is a product that can do that. And with BioProtect, although you can't maybe get rid of the Vicryl balloon itself, if for some reason you wanted to deflate it, you could physically pop it actually and aspirate out the fluid. And then in terms of visibility, SpaceOAR has a iodinated contrast version. They also have an uniodinated contrast version, so it's very easy to see on CT scan, which is very appealing to rad oncs. The Barrigel product does not yet have any iodination, so that's a little bit different. And BioProtect, the company doesn't officially endorse it yet. They say you should fill it with normal saline, but there's lots of people out there who are in fact putting small amounts of iodinated contrast in there so that they can visualize as well, but that is not something that the company specifically recommends or endorses. So here how these look when they come in the kits. This is the SpaceOAR product. It reminds me a lot of when you go to Home Depot and you buy a 2-part epoxy syringe. And I'm not saying that to denigrate the product at all. I think it's a great product, but it kind of has that idea where you have 2 compounds and then there's a mixer tube, and then when you inject them, they polymerize, and so that's one of the issues is that you can't sort of readjust it during the injection much. The Barrigel product comes in these little 3 cc syringes. They give you 3 per kit, so you got 9 cc's that you can play with in any one kit. And again, because it's not a polymerizable product, you can use it to sort of sculpt. So you can move your needle here, move your needle there, and hopefully that gives you a bit more control about where the product goes. And then this is what the Vicryl balloon spacer looks like. It's about 48 millimeters long, and when it's filled with up to 17 cc's of fluid, that gives you something like a 15 to 18 millimeter height. And it's made out of the same stuff absorbable sutures are. It's like Vicryl. You might say, well, Vicryl sutures, maybe go away in 10 to 20 days, but this is, again, a longer degradation because the Vicryl is a little bit thicker. Because most people are unfamiliar with the balloon product, I'll just show you a little bit more how you introduce it. You have this little assembly where there's a needle, and then over the needle is a blue dilator, and then over the dilator is a sheath. And it's almost like, urologists will appreciate this, almost like putting in something over a guide wire. You use the needle to get to just at the urogenital diaphragm, but then you use the dilator to do blunt dissection into non-villous fascia, and then you take the dilator out, and then you have a conduit that's left with the sheath to put the balloon in, and this is what that product looks like. So at the end of this device, which you can see on the left of the screen, there's a balloon wrapped around the tip, and you can see on the kind of the lower part of the slide here, this is sort of, I can't get rid of this, what the balloon might look like inflated. You would attach a syringe there, and the syringe will put the normal saline down the fluid into the balloon and inflate it or deflate it. So this was a study I did that's now under review, and it was kind of like a learning curve study, but these were the first 10 patients I ever attempted with all three products. So this is like when I wasn't really familiar with any one of the products, how well did I do? And it doesn't really show well, but you can see that you can get pretty good space with any of these products actually. If you look kind of closely, because this image was calibrated very scientifically to be at the centroid of the prostate, which is about where the mid-gland should be. And you know, my general impression of it is you get more reliable space with the Vicryl balloon, and that again has to do with the fact that it's sort of constrainable. But you can get good space with any of these products when looking at them at the mid-plane. So let's get to a fundamental question, though. It's okay, we got these three products, but people have called into question, should we even space? And so let's make some arguments, you know, why we do that. So why do we put spacers in? Well, we want to isolate the treatment to where it's needed. We want to exploit the greatest gap in the therapeutic ratio. And we want to keep exposure to normal tissue. Rad oncs will understand this term, ALARA, which stands as low as reasonably achievable. And, but, you know, why these bullet points? Because if we do those things, this should lead to better quality of life. And here's a major distinction that we have to draw. Studies historically have forever been focusing on toxicity, and more contemporary studies, thank God, I will say, are focusing on patient-reported quality of life. Toxicity is graded by a physician. In other words, the patient is telling you what they feel, and then the physician is making an impression about how toxic the treatment is. Whereas a quality of life form is patient-reported outcome. There's no interpretation by the physician. And I think these are critical concepts to understand about how we evaluate our therapies and how they affect patients. So what I will tell you is that toxicity grading sucks. And I'm sorry that I use, maybe it's minor profanity. You see a couple papers here. There's one paper on the left that says, I'll just read the conclusion, the range of measures used and symptoms captured vary greatly across reviewed studies. Regardless of concordance metric reported, agreement between CTCAE, which is toxicity grading, and patient-reported outcome ratings was moderate to best. And if we look at something a little more related to prostate cancer, this was a prospective study, very well done, where they had both patients and physicians use CTCAE criteria specifically. And what they learned was that there is a 70% disconnect in the severity between how a physician perceives toxicity and what the patient perceives. And so in other words, there's only 30% agreement. And when there is disagreement, 50 of the 70 times, the patient had worse toxicity than what the physician was grading. 20 of the 70, the physician thought it was worse. So let's look at some contemporary trials, because it's been called into question. Like, I've seen editorials in our journals that say toxicity is so low from modern techniques that we don't even need spacers anymore. Okay, well, let's look at the PACE-A and the PACE-B trial. The PACE-A trial was a radical prostatectomy, surgical robot versus SBRT. And we're not going to focus on the red because that was the surgery patients, although you could see how well you guys do. But these are patient-reported outcomes for bowel bother. And I will tell you that a 4 to 6 point change in this scale is considered clinically significant. And so you can see here that even though this trial showed super low toxicity, this quality of life form shows you where the medians lie on the bowel function. That's those little white lines. People had no problems, and going out over 2 years, you are below an MID, in other words, a clinically significant issue for years. And if you look at the PACE-B trial, that was actually an SBRT versus conventional frac. You can actually see here, if you look at the actual question about bowels, no problem, very small problem, there is definitely a shift, and there are more people that rate small problem and up forever. And you might say, well, small problem, small problem. Well, I tell you what, I have chronic small problem issues that I won't share with you, and small problem issues are terrible. You know, like they're in the back of your mind all the time. I've got something, it bugs me, I know it's not gonna kill me, but I assure you, I wish it wasn't there. So anyway, that's PROs. Let's talk about the paradox of spacers. Spacers are designed to protect quality of life. And unfortunately, in a rare circumstance, they do exactly the opposite, which is create devastating quality of life. So this is a paper from the MOD database, which is an FDA reporting tool, showing that people who had SpaceOAR specifically, it was very rare, but there are a few hundred patients in there who got some pretty significant like grade 3, grade 4 toxicities. Is it super rare? Yes, it's super rare. The denominator is something like 200,000 patients, and they're reporting on a few hundred here. But what I will also tell you is that this is sort of underreported. So you're putting in a spacer to save the bowel, but sometimes you can create a fistula or that ends up in a pelvic exoneration or even death. So these are things that we want to avoid. So we all have secrets, and here's my secret. I'm the guy the lawyers call when someone gets hurt from a spacer, and I think maybe Dr. Oreo might be the guy that lawyers call as well, and they need an expert witness. So I've got a lot of insight into what's going on around the country. And what I learned doing expert witness work is that spacer injuries are kind of underreported. And even in the most experienced hands, you can still get these problems. And the injuries can be devastating. And I would even argue in the most experienced hands, you should see about a 1 in 150 complication rate that's something like grade 3 or higher. Some kind of fistula, maybe it's not devastating, you might have to reduce. I know there's lots of people who remember like, I've put in 500 spacers, I've never seen it. I get it, it's a numbers game. It's gonna happen, I promise you. So if you compare this to sports injuries and you say it takes 20 minutes to put in a spacer and you say the injury rate's 1 in 150, spacing is a little bit more dangerous than motocross and a little bit less dangerous than soccer. Okay, so what's the root cause of the toxicity? The root cause is putting the spacer in the wrong place. You can see a video on the right. We are actually not in de non-veliers. We are under the serosa, and that is a bunch of spacer being blown in to the rectal muscularis. What happens is these tend to be stable for a few months, but when they start to degrade, that's when you tend to get a fistula and an injury. And so here you can kind of see this MRI example of what happened here with this physician. That was the SpaceOAR product. This is a vesicourethral fistula with superimposed osteomyelitis. This was a salvage case. Patient had proton before, came in for a salvage brachytherapy implant. Barrigel was placed in there. I'm not sure this is due to the spacer. It's hard to tease that out. Part of the problem here is that this patient got electrocautery a few months later for some duskiness on the rectum, and so I'm not sure Barrigel or anyone else can be blamed, but it's hard to tease out the differences here. This is a Barrigel that's everywhere but the de non-velius fascia area. There's some in the rectal wall. There's a lot in the prostate gland. This patient, by the way, is asymptomatic. I can't tell you that there's any injury here, but this kind of misplacement leads to delay. This patient is going to wait it out till it dissolves. They didn't want to go in again with a needle and use hyaluronidase. I decided to try the balloon because I thought that these types of injuries could be mitigated. The nature of those injuries are putting sharp dissections where you don't want them. The way you put the balloon in is, again, you do not put the needle much past the urogenital diaphragm. Use the dilator to dilate. And so I'm not sure if this will play, but here's a video. The dilator tip's right here, and you can see where the prostate is. And now we're going to use sort of blunt dissection. Give me a sec here to see. That's actually the needle that I'm using as a guide, poking out just to prove I'm in the right place. And let's see what happens here. And now I'm putting the dilator through. Hopefully you'll see me do that. I'm not sure I took such a long video, and I know I'm running out of time. But it's that blunt dilation that, in my opinion, is potentially going to mitigate these spacer injuries, because I don't think you can get under the muscle there. So I'll probably stop this video here. So here's, and I know I'm already going over, but I'm going to just take another minute or two if that's okay, Dr. Rossi. So what's interesting is, if you look at toxicity measures, the distance between the prostate and rectum matters throughout the entirety of the prostate gland. It's kind of curious. But if you look at quality of life measures, which I would argue are the only ones that really matter, it's very interesting. The only place that matters is how separated apical space is. And ideally, you want more than 10 millimeters at the apex. I do not have a biological plausibility argument, but I can tell you that that was determined from Barrigel's pivotal randomized trial. And they say the percentages of patients with bowel minimal important changes were 14.8% for people with greater than 10 at the apex versus 36.6% less than 10 at the apex. This finding was discovered years ago before spacers by Dan Hamstra, where they looked at what changed quality of life, prospectively collected measures. They did a kind of similar study, had nothing to do with spacers, but they broke the rectum up into what is effectively apical, mid-gland, and above, and they found the exact same thing. The only thing that changes quality of life measures is apical space. So we presented a work looking at, again, the first 10 cases. It's a learning curve paper, but if you kind of look at how much space you can achieve, and I don't really want to, let me maybe go back to this. This is the one slide that'll show it all. You have base, mid-gland, and apex for the three products. Everyone's good at big separation at the base, but actually the Vicryl balloon is very reliable at always getting above that 10 millimeter at the apex. You can see the median space distance is something like 14, and even the interquartile range is above. So there's something about this particular product that's a little distinguishing, where you get much better apical spacing, even if you're relatively inexperienced at doing that. These are sagittal views of the balloon, just kind of showing you how good the space is and how it tapers up at that apex, which is perhaps why it achieves that. I'm going to skip over this video, even though you might want to see it. So what have I learned over 700 spacer cases? It's all personal opinion. All the products are easy to learn. And personally, I've actually not had any significant complications with any of the products. I've probably put in 300, 400, 500 SpaceOARs, probably 200 Barrigels, and probably about 200 balloons. So far, I haven't been burned yet. I have been burned in a salvage patient. I would say the learning curve is about 10 to 20 patients. I think each product kind of has its merits and demerits. I have a very strong preference for one over others, but I'll let the evidence in this talk speak for itself as you guys make your own decisions about how you may want to go forward. But thank you so much, and thanks for letting me go over.